Hi, welcome to this symposium. I am Pascal Pujol from the Medical School of Montpellier, and I'm very delighted to chair this symposium. We are going to talk today about two fascinating achievements of what genomics could do in precision oncology in two cancers, breast and ovarian cancer. And so the session will be divided into two parts. On the first one, we will talk about HRD in ovarian cancer, and then we will move to genomic signature in breast cancer. As you can see, you've got a QR code for Q&A questions live and also for polls. We would like you to interact with this tool. We're gonna start with the introduction of our speakers today. And it is my pleasure to introduce Carsten Denker from the University of Marburg. He's the director of the Institute of Pathology, and he will co-chair the session with me, particularly the second one on breast cancer. We do have also Frédéric Marmet, which is professor of gynecology at the University of Mannheim. And Benoît Hioux is professor of medical oncology at the Hospice Civil of Lyon. Hi, Benoît. And finally, I have to apologize for Professor Kischle that could not make it for the meeting. She's a little bit sick, probably COVID, not so grave, but we have the pleasure to have his collaborator, which is Dr. Klein. Thank you to be here. To finish with the introduction, I would like you to present yourself too and to answer this poll that will be also finally a way to test our upcoming interaction in this meeting. And so which category best describe your professional background? Is this medical oncology, gynecology, pathology, basic science, or industry professional? One thing is maybe missing is patient advocacy, and if there is patient advocacy, we apologize and just raise your hand, please. So this is the result. It's pretty equilibrated, actually, session with medical oncologist, industry, and very interesting to have this picture. Thanks a lot. Okay. It's bad for a chairman, but I will start to speak, actually, just to give you an overview and trying to answer two questions. In the first session dedicated to HRD in ovarian cancer, there is two questions. Why should we use HRD? And maybe, what is HRD? This is my disclosure of interest. Why? I mean, the reason is pretty simple. We have to realize that PARP inhibitors is a major improvement in the care of ovarian cancer. And therefore, it's in the guidelines of every referential in different areas, because we should have HRD status for any single woman with an ovarian cancer at diagnostic of recurrence. And the reason is simple. It's just in one slide. This is maybe one of the most impressive results of target therapies in solid cancer. This is the curve from Paola's study, but I could have put any other randomized clinical trial comparing PARP inhibitors once you've got a BRCA mutation or an HRD profile. So this is the reason why we should provide HRD to every single patient. What is HRD? HRD is inability to repair double-strand breaks in the DNA. And via a pathway called homologous recombination pathway. This is what is HRD. How to look at that? I mean, first thing is to have BRCA mutation, of course. But another thing is to look at some kind of genomic instability. And this is what is my choice. My choice pulled together these two information, BRCA mutation and genomic instability. That is actually the sum of different genomic alteration. One is called telomeric imbalance. The second one is called large-scale transition. And the third one, you know, it's loss of heterozygosity, LOH. Okay, you sum this and you've got a score. And this is what defines HRD. Historically, that was the first approach developed by Myriad Genetics. After, we've got a lot of other developments of HRD. On the left panel, you can see what recently academic milieu have developed. It's about genomic instability. Recipes are different from one to another. On the right panel, you've got other commercial tests. Only another have been tested in clinical randomized trial is the one from Foundation Medicine, which is actually LOH. And finally, you have other approaches that are under development, such as RAD5140, HRR panels, and finally, pathology applied to IA. We'll not talk about these tests because they are really in development. Okay. So let me ask you a simple question. Are HRD tests interchangeable? Thank you to start the poll. Okay, so approximately two-thirds answer no, this is not interchangeable. This is all about what we're talking about in a few minutes. But fortunately, I have to remember this. Even if you compare the two solutions that have been validated in clinical randomized trial, which are actually the LOH for Foundation Medicine and MyChoice from Myriad Genetics, I mean, only 0.84 are concordant. So even if it is gold standard signature, you have important differences. So these signatures are not interchangeable. So this is the subject of the roundtable we're going to start. How to deal with that? What are the criteria of validation of HRD test? From pre-analytical to clinical validation. We're going to discuss about that because evidence-based medicine is not only for drugs, it's also for diagnostic and companion test. And this is the reason also why we do have Delphi consensus work guidelines involving more than 100 experts worldwide try to define this important question about which test is really relevant in clinical practice. So let's move to the round table, and this is my oh, it's so fantastic. So I have a question to ask to Benoit first. Benoit is a clinician. I mess a little bit, actually, because you know what? That's the problem when you invite French to moderate a session. And will you please, actually, Carsten, emphasize the problem of testing and actually of local testing of HRD? Thanks.
Yes, thank you very much. It's a pleasure to talk to you and to report the results of our local HRD testing that we are currently doing and that we started to do in our Institute of Pathology in Marburg. This is my conflict of interest statement. So actually, in 2019, we realized that there would be an emerging problem for diagnostic molecular pathology, and actually this problem came out of a very, very positive result, which was the positive result of the POLA-1 trial. So it was very clear that this is a very clear biomarker situation. We now have a subset of patients that are biomarker positive, HRD positive, and they have a benefit from a very, very promising and excellent therapy. At that time, there was no HRD testing available in most institutions, so we had the challenge that this needed to be done in a reasonable timescale. It's also very important to notice that external molecular laboratories are not really an option in Germany. So they are not accepted by academic pathologists because we as pathologists in the university hospitals and the large pathology institutes, we want to make the diagnostic assessment very close to the patient treatment situation. So we do not really like shipping samples to large central facilities. And actually there's also no reimbursement if a test is not performed at least in Germany. So what I will share with you is the experience of the molecular pathology team in Marburg. I will show you the data on validation of the Myriad MyChoice assay in our academic molecular pathology lab. The comparison with the central testing in the central Myriad laboratory in Salt Lake City. And the question is actually then, what is, based on our experience, if you are sending samples for HRD testing, what is the best type of samples and how can we maximize the success rate for that? So actually, right after the ESMO publication in 2019 of the POLA-1 trial, there were discussions with the Myriad teams, and the decision was that it would be a very good idea to transfer the complete Myriad MyChoice assay to a central academic laboratory in Germany as one of the first European laboratories that are performing the original Myriad assays. So when approximately in November 2020 there was an EMA approval of olaparib for the maintenance therapy in high-grade serous ovarian carcinoma, we were able within a few weeks to deliver the first HRD report done in the molecular pathology lab in Marburg. It is very important that you have at least one basic idea of what we are actually measuring and what is the scientific basis of this. Actually, there are three important publications which are shown here. The top one is actually research from Myriad in Salt Lake City. The other ones are from research groups in Dana-Farber and Institut Curie. And all those three groups looked into what is typical for a BRCA-mutated tumor? What is the DNA structure of a BRCA-mutated tumor? And each of the group identified another feature of those tumors, and they are called LOH, TAI, and LST. And basically, you can remember this as a very simple explanation. Whenever there is a DNA double-strand break, you have obviously two ends that need to be put together. And if there is an intact HRD, the cell is looking that exactly the right ends are put together. And if HRD is damaged, it will just take anything out of the DNA and just put the DNA together in a very confusing way. And this is the main feature that is analyzed. And typically, those are DNA ends that are very long. So we are looking for very long DNA strands that are put into the wrong position. And this could be in the middle of a gene or at the end of the gene, or it could be large insertions. And this is what is called LOH, TAA, and LST. And it's different from the mutations we're detecting. Mutation is typically just one base or a short area in a gene. Here, it's like a puzzle, and the puzzle is put together in a very bad way, and very large regions are not in the correct direct area of the genome. So the formula for this is LOH plus TAA plus LST is the GIS, so genomic instability score, and this is how HRD is calculated. And it's very important that those three elements are put together, because here you see the analysis for the three separate elements, and everything that is here a dark column is a BRCA mutated tumor. The other ones are BRCA wild type tumors. You see that there are two groups, but they are not so clearly separated if you just look into the individual parameter. If you put them all together, you will have a very clear separation of actually two different groups, with a cut point that was selected to be at 42 to have a maximum discrimination of those groups. So if we just look into the EMA approval, we find exactly the same information. So in the EMA approval for olaparib with HRD testing, it says you need to have LOH, TAI, LST, you need to have a GIS and a validated cut point. So if you are thinking about using an HRD assay, it's a very good idea to check if this is based on those three parameters and if the cut point has been validated. So when we implemented the Myriad MyChoice assay in the Pathology Institute in Marburg, we did a validation. So for the first 500 cases, we did a parallel investigation in our lab in Marburg and in the central lab in Salt Lake City. And to put everything together, there was an overall concordance of 79%. So just those few cases that are typically very close to the cut point are different, and there was a very, very good concordance in a very large number of basically unselected cases that came for HRD testing to Marburg. And also, if we look into the distribution, we can reproduce very nicely what has been observed before. So we have evidence from this is now a cohort of 2,300 samples analyzed in Marburg. We have evidence that it was actually really a good idea to select a cut point at 42, because you see it's really a bimodal distribution. So there are actually two different groups of tumors, which are HRD negative and HRD positive. And also, you could see that if you look into the BRCA status, you have the BRCA mutated patients. They have typically a higher GIS, but there are also GIS positive patients that are BRCA negative, and there is just a very few, 1% of patients that have a BRCA mutation, and they have a lower GIS. This is a distribution of patients that we observed in Marburg. So in those first 2,400 patients, basically we could really reproduce that this is a marker that is relevant in the real-world clinical setting. So we have approximately 45% of patients that are HRD positive, and a lot of them are BRCA wild type, some of them are BRCA mutated, and the red group is actually the group that gets a new indication for olaparib that you can not get from a mutation analysis of the germline or a mutation analysis in the tumor tissue. And if I just mirror the identical plot from the 806 patients that were in PAOLA-1. In PAOLA-1, there were 48% of the patients HRD positive, and you see that you have a very similar fraction of HRD positive tumors in the clinical trial and in the real world. And this is really insurance because we have seen some biomarkers that were relevant in a clinical trial, but we never see a positive patient in the real world. And for ovarian cancer, it's very clear that approximately 50% of the patients have a positive HRD status. We are missing a few patients in Marburg, so in Paola it's slightly higher because we are obviously not getting any sample where there was a germline BRCA mutation because they don't need to test the tumor, they are HRD positive based on this germline analysis, so there will be another 5%, 8% of patients in Germany that get the treatment, but that are not tested with a Myriad assay. So the question is, what is the success rate of HRD testing in this real-world cohort if we would have optimal pre-analytical conditions, and can we give some recommendations for samples for HRD testing? And we investigated this in the cohort evaluated in Marburg. So we took approximately 2 years and we got 2,700 requests and samples for Myriad MyChoice HRD testing. There was a small number where we saw immediately that this is not a suitable sample because it was not the correct block, no tumor at all, just necrosis. So we asked for new tissue samples and we got new tissue samples in half of them. So we started the workflow for 2,654 patients in Marburg. And this is a success rate. If you just look down here, we had a valid HRD status in 90% of the patients that entered the analysis, and we had 88% of the patients where everything worked with the first sample. We sent requests for additional samples for some patients, and we received some of them and we added them to the workflow. And if we get a second sample and the first sample was not working, there was a success rate of 33% that this will work in the second one. So it's important to remember that in Paola 1 the success rate was 82%. So it's higher now in the testing in our laboratory, and I think the best explanation for this is that everybody is more used to sending samples out for HRD testing. We had the option to talk to the local pathologist, to talk to the local centers that asked for a second block, and this has increased the success rate compared to the Paola 1 clinical trial setting. Also, it's very important, we did not reject any sample for HRD testing. So if somebody decided this patient needs an HRD test, we just did the test, and as a result, we have different types of tumors in our analysis. And here on the left, you see the high-grade serous ovarian carcinoma, and the success rate was 92% from the beginning. We got a very small number of low-grade serous ovarian carcinomas, but we just had 72 success rate, and they also failed the reanalysis. And if we look for special types like clear cell or endometrioid, there also the success rate is slightly lower than for the high-grade serous ovarian carcinoma. So if you would stick to the most relevant cohort, the success rate is much higher than if you include other types of tumors. Obviously, the recommendation now would be you should not do HRD testing in low-grade serous ovarian carcinoma because there's no clinical consequence based on this. Then we looked into the tumor cell content in the tumor area, and here on top you see a tumor with a 90% tumor content, and here you see a tumor where there is just a minority of the tissue covered with tumor. And we found that the tumor cell content, the lower tumor cell content, was associated with a failed test, and also a low tumor area was associated with a failed test. So we combined those. And here you can simply see from the color coding what is the area of tissue where you are safe for HRD testing. So if you have a tumor cell content of at least 30%, and if you have a tumor area of at least half a square centimeter, everything that is above this will have a success rate in the high 90% range. And even if one of the parameters is not optimal, it may work, but we recommend to select samples that are from this range of tumor cell content and tumor area. So if we look across the workflow that we did in Marburg and the timeline, there was Paola 1 in 2019, there was an EMA approval in 2020, and then we started to do the assays, and in 2 years we did approximately 2,700 HRD assays. 45% of those were positive, which would result in therapy options for approximately 1,200 patients, obviously depending on the definite clinical decision and clinical situation. If we calculate the amount of cancer that has been diagnosed in Germany, ovarian cancer, this would be approximately 7,000 a year. So this would be approximately 20% of the German patients with ovarian cancer. And now we have a successful German HRD ring trial. So we, in Marburg, basically filled the gap for 2 years. And now there are other pathology institutions that can also do HRD tests. And we are still doing approximately 100 tests in a month in Marburg. The most remarkable observation here is that even in Germany, in this time, we have only 20% of patients that have access, that had access to the HRD assays. There may be good reasons for those, because if the patient did not get bevacizumab, they would not do the maintenance therapy, and there could be other indications for that. But nevertheless, it seems very unlikely that the additional 80% of patients would not benefit from HRD testing, and they were also not tested at other institutions because at those times there were no additional tests. So I think it's a very important question for discussion to have a broad access for patients to HRD testing. So summarizing everything, we have been able to successfully implement the Myriad MyChoice assay for decentral testing in academic molecular pathology with a high overall concordance rate and a high success rate. The recommendations for samples for HRD testing would be, please do not send low-grade serous ovarian carcinomas, and there should be 30% tumor content and half a square centimeter of tumor tissue. And there are therapy options for a large number of patients in Germany based on this assay, but currently only 20% are tested. And I would like to thank the team from Myriad and the team from my institution that worked in the implementation of the HRD assay. Thank you very much.
Thanks a lot. Thanks a lot. I would like to have the view of a clinician, and maybe Benoit, for you as a clinician, how would you consider the validation of an HRD test?
It's a very important question. I think from the clinician point of view, the first statement is we need HRD. We need access to HRD tests for our patients. We have to remind that in Paola trial, we are talking about overall survival. So the patients who have HRD positive test have an improvement of the overall survival, about 40%. It's 18 months of overall survival benefit from olaparib plus bevacizumab, but we also have very positive results from other PARP inhibitor, Prima trial, etc. So the answer is yes, we need access to HRD tests for our patients, for prescription, for adjusting the prescription. Now, we understand that we cannot just have access to only one assay, that we need development of other tests, that we understand. But I must say that as a clinician, we have been a bit confused, a bit puzzled with the number of tests, academic, industry tests, with different validation figure. Maybe we can show this figure, because we are easily confused because you have the GIS correlation. Okay, what is a good correlation? There's a ROC curve, so we are used to ROC curve, and also the survival curve. And you have it for all tests. And the question is, does it mean that they are interchangeable? And it looks like, based on the questionnaire, clinicians are not necessarily, they don't necessarily agree. More than 60% think they are not interchangeable. But we need this test. And so I think it's important to have this discussion. What makes them interchangeable or not, on a biological point of view? For us, I can give the opinion of clinician, but I will let you to answer. And the next question is, does it mean if we were using this test prospectively, would have exactly the same results? That's my question to you.
Thank you very much. And I think to keep going on this clinician problem, I will ask Frederick to comment this poll, and we will interact on this question. But because not only we have to face multiple possibilities to perform the test, but there is another question. What is the order? Should we start by BRCA testing, then move to HRD testing? Should we do it in parallel? So please, before we're gonna obviously try to answer the question of interchangeability, let's add this complexity also of when should I ask the test as a clinician. Could you start the poll maybe? And if you want, Frederick, to comment this question.
I think something that can be observed within Europe, I don't know too much about the United States, but in Europe, people do it within the community completely differently.
Yeah.
And I think all the ways that are being done are fine. The most important thing is that it's not forgotten, or in the track of things, when you get your patient, they're operated, you have them in a multidisciplinary trauma board, you decide what you do. And if you do one thing first, then they go to the day clinic and get their therapy, and they see different doctors, maybe different doctor every second time, and things get forgotten. And this is the take that I have, and I chatted to some European colleagues. They viewed that quite similarly. I really am afraid that if I do it sequentially, so I do it concordantly, so I do germline testing, I think this is really important and adds an information that we're not receiving from HRD testing, even if it provides the somatic BRCA status. But we need to also be able to identify relatives at risk. And so this is something that shouldn't be missed. And I'm really afraid that if we do it sequentially, at my institution at least, that there will be a proportion of patients ending up not having the test, and it will be realized at a too late stage. So when we should have started bevacizumab and then having a strategy.
Okay, so that's important. I mean, the poll is another question, but this is a very important point. I think the only thing is maybe resource. And in some country with a resource stratified, resource limited, maybe you can do this sequentiality with BRCA testing, then move to HRD. But in clinical practice, I think it's really safe, more safe for the patient to do both.
I think I would support what you said. So resources are an issue. And this is not really economical. So this is not the best way to do it, but to me it's the safest way. And I think also access to testing is the most crucial thing. Yeah. And this is with limited resources. I think there's lots of different layers that play a role.
Okay. During this question, I mean, you thanks answer this one. And what is the ground actually to consider an HRD test? And actually, you must agree that the ground is a clinical validation. And would you agree with the answer of the audience?
Yeah, because we have to remember what is the final point of this test is at the end to prescribe the right treatment to the right patient. Yeah. So we cannot do better than clinical validation. I would say a prospective validation is definitely the gold standard. Okay. We can discuss about all the efforts done on the Paola trial dataset if it was prospectively done. It was prospectively done for Myriad, but for the other tests, do we consider they were prospectively validated? It's a question. By the way, I think it's time to congratulate Gineco and Professor Eric Pujadt-Lorraine, who found this idea of saying we'll use the dataset of Paola for validating other HRDSs. So I think we really have to acknowledge that. Now the question is, do we consider the other tests have been prospectively validated based on the data we have?
Well, what is your feeling?
Yes, I will comment this from the view of the pathologist. So obviously it's a very good idea to validate an additional test or a new test in a clinical trial. But the other question is, if we would do this as a standard procedure, it would mean that we would use the tissue from clinical trials for validation of additional biomarker assays. And I think for PAOLA-1 this is perfectly fine, but as a general approach, there may be situations where we would like to do something else with the tissue from a clinical trial than just showing that test B and C and D and E and F is performing similar to the original test. So in this situation, it may be a good idea to save the samples from the clinical trials for additional subgroup analysis or anything that may up. Today we would say about spatial profiling and all those things, and think about other options to add additional tests. And in this situation, if you have a test that has the identical principle, so in general, it's measuring the 3 elements of HRD that have been predefined. And if this test shows an acceptable high concordance with the gold standard test, from my point of view, this could also be an option for validation, because we will not have the very good situation of PAOLA-1 in all clinical situations, but we probably need more than one clinical test for any given question, because it's always better to have more than one option.
Thank you. You show really nice work in Marburg. And it's such a nice work that I think that you have less non-contributive sample than in Central, if I well. So how about that? How about this non-contributive? Do you have data from PAOLA trial, for instance, to validate that your non-contributive samples are pertinent in terms of clinical response?
Yeah, that's obviously a very good question. So for PAOLA-1, the non-contributive samples were in the HRD negative group, and there was no benefit seen in those. So you could assume that many of them would not be HRD positive. And this is actually, it is in line with what we're seeing. If we have a sample with enough tumor cells, with enough tumor tissue, and it comes up as no result, and if we would repeat the sample, several of those come up as HRD negative, and this is particularly for and this could be interesting for PAOLA-1 as well, for the rarer subtypes, because the algorithm works optimal in high-grade serous ovarian carcinoma, it's working in endometrial carcinoma. It's not really working that good in clear cell, interestingly, because the algorithm needs to detect the tumor cells. And if the tumor cells are very similar to normal tissue, it will simply say, this is a low tumor content, I will not give out any result. And this is a situation where the sample will be reported as no result. And very likely the result behind this is it's HRD negative because it's similar to normal tissue. But we cannot use this for interpretation, but it can explain some of the non-conclusive cases, actually.
Okay.
May I just jump in, because I think that's a very interesting aspect from the diagnostic point of view, but also from the clinician's point of view, because we are left with the question, what do we do with those patients where we don't have an HRD test result? So we have to decide. And so we cannot go and say they're likely to be HRD negative. And I have to take on that I treat them as the HRD positives, because I think if they are, the gain they have from giving them a PARP inhibitor, they're so great. But I see your point, and I saw that also, that having a different tumor biology, like low grade, and maybe tumor cells looking more similar, the chance of them being HRD negative might be higher. But from the clinician's point of view, I think most of us would be treating them as if they were HRD positive.
Okay. Very interesting. Thank you very much. And is there any question in the room, actually? I do have one, Carsten, about HRR gene panels, because it has been a strong direction. And what is the point, actually, now? Can HRR gene panel, or which of this gene could be informative in terms of PARP inhibitors prediction response.
Yeah, so this is a very important issue. We know that DNA repair is complex and that there are many molecules involved. BRCA1 and BRCA2 are the most important ones, but there are a lot of other ones and they can also have mutations. The message is you cannot do a mutation panel of 10 or 12 HRR genes and replace HRD testing by this. BRCA1 and BRCA2 is important, but these are so far the only genes that really contribute to the HRD status. So you do not need HRD testing if you know that it's a BRCA1 or BRCA2 mutated tumor. But for everything else, there's not a solid correlation. So you cannot replace HRD by just a larger gene panel. It's not possible.
Okay. How about PALB2 and RAD51C and D that looks to be in some cases very
they are very
responsive.
important, and we are actually we have those genes also in measured in the patients measured at my institution, and we are correlating this, but this is not a strong correlation, so you cannot say anything. If you just know a single patient with a PALB mutation, you cannot say anything about the HRD status.
Okay, I think we have to move, and I will ask each of you to. I was supposed to do the job, but finally I'm a little bit tired. No, just to make the conclusion, I will propose that each of you say a simple message to the audience. And so, what Benoit, will be your message actually as a medical oncologist?
I would have several messages. The first one is we need access to HRD tests for optimizing the prescription to our patients. This is the first one. So all centers treating patients with ovarian carcinoma should have access to tests and tests that are validated. So be careful and check with biologists that they have been validated. The second one, we need to reduce the number of non-contributive results because it's very complicated. The third one is, I think we need to also assess the heterogeneity of practice, because I'm afraid that in Europe, but even around the world, the heterogeneity must be very impressive. I'm a bit afraid, a bit scared about what results of trials, of real-life study we will get in the future if the heterogeneity is so large. So please aware that we are launching a project with Alexandra Leri and the GYNECO, and it's part of a Salvovar program, a European program. We make a big survey to understand what tests are used where in different parts of the world, how they are funded. So at least we can have a whole picture of what is used where, so we can understand how the policymaker must move to guide the centers in the choice of the tests.
Thanks, Benoit. Frédéric, maybe?
Just not to repeat all what you have said, because it's all true. I think it's also important to remember that HRD status gives you an understanding of the patient's biology. And that's not only important for prescribing the first-line therapy, but it's also going to be important to interpret what is actually going on the way. You know, how should I interpret a PFS or platinum-free interval if I don't know if the patient is HRD positive or not? And this will influence, let's say, all the next lines of therapy and choices, maybe even choices of performing surgery in the recurrent setting and all that. So this is one thing. I think the cutoff is something which is important. And I didn't believe, but I really had 2 patients coming into my clinic which had an HRD test from a large academic center stating they were HRD intermediate. So this is, from the pathology point of view, probably a safe bet. You know. But for the clinician, this is...
One is listening at us. Be careful. Yeah.
We know each other quite well.
Okay.
Yeah, it's not his... No. I mean, I'm in the comfortable situation that we've been sending our samples to his lab, so I think even the first one might have been ours. Yeah. So the conclusion, access is important and validation is important too, but there needs to be a variety because also to ensure that all patients have access to testing.
And HRD will be one of the components to understand the pathology of and the history of
and also clinical behavior, because I mean Benoit has done so much nice work on response and KELIM, etc. That's all part of the puzzle, and we all need all these informations. That's important.
Thank you. A last word, Carsten?
Yes, okay. So I'm always like taking the pathologist view. So what I would like to emphasize is that in our pathology departments, we want to do the genomic assays, we want to do the sequencing assays and the HRD assays, and we are able to do it. And we think that it will be beneficial for the whole scientific and medical and clinical community if those tests are performed at academic labs. So it was really a very good strategy for Myriad to talk to central labs in different countries, and there will be additional labs also in other parts of Europe to allow a decentral testing in academic lab. And for us, it's very nice that we really have confidence into the assay because we are seeing the results on a daily basis and we can access all the quality control measurements. I think this is very important, and it's also relevant for other upcoming molecular assays.
May I make a last comment?
Sure.
Because what you said, if we didn't perform that in academic centers, we would never see the data that you produced and published. It would just test results and that's it. But what you produce in terms of data is so valuable. So this is really important to also have this testing done in academic centers.
Yes, actually it's both local and centralized, and we do have the same in France, and that's a very good idea from Myriad to do that. Okay, well, thank you very much. We can talk a lot more, but maybe after, and we have to move to the second session, Carsten.
Yes, so we will switch the topic for the second part of this session, and we will look into new data for EndoPredict. Actually, this is not related to ovarian cancer, but to breast cancer, and I have the privilege to chair this session. We will have a presentation by Dr. Klein, but before we do this, I will do one of the poll questions. So just to get an idea what you are currently, how the treatment is for patients with ER-positive, HER2-negative breast cancer, several guidelines recommend that molecular profiling is done. So the question is, what is the percentage of patients where you are doing a genomic assay in this setting? Actually, there is a similarity between the Myriad MyChoice and the EndoPredict assay, and this is also one of the reasons why we are presenting this together, because both of the assays are performed in local pathology labs. So for EndoPredict, there are approximately 20 to 30 labs in Germany and many others worldwide, and this is also an assay that can be done locally. So we have 0 to 20%, 27 of you, and more than 50%. So approximately a lot of people are doing testing. So the majority, I'm just calculating, 2/3 of them are doing testing in some clinical settings, and for 1/3 of you are not doing any testing. Okay, so with this, we will come to the first presentation by Evelyn Klein on an introduction on the EndoPredict testing. Whoops, just go ahead.
Thank you very much for the friendly introduction, and thank you, Myriad, for having me here. So I don't know if you can see the first slide. Ah, there you go. There you go. All right, so I was a bit astonished seeing the percentages that you answered there at the moment, because 1/3 of you said they're doing no testing. What is this all about? We're talking about early breast cancer, hormone receptor positive, HER2-negative breast cancer, and this is the biggest cohort we are all treating. And we know that the prognosis of those patients is really good. for most of the patients, but some of those patients are having a higher risk of relapse. And I remember actually Nadia Habeck giving a talk a few years ago and showing Kaplan-Meier curves of especially these patients that we are calling luminal B patients, and they are really running similar with the Kaplan-Meier curve than the triple-negative patients. So we really have to put our finger on this patient collective and see if they don't need more than endocrine therapy, meaning chemotherapy. And this is what it's all about the testing. There are several tests on the market, and my speech today will be on the EndoPredict test, as Carsten Denkert already announced here. So giving you, those are my COIs. Giving you a small insight about the test. I don't know how many of you are familiar with the test. It's a second-generation test. It's a 12-gene molecular score, and it's performed in fresh frozen tissue. And what is very charming about the test, that it also incorporates clinical parameters, meaning tumor size and nodal involvement. And we know that this is very clever to do that, because this has a great impact on the score we are getting. We are then getting an EP Clin score, so EP standing for EndoPredict, which is the gene signature, and then we get the clinical features, the tumor size and the nodal involvement. And then we get the score, and it's a threshold of 3.3, meaning that you have a 10% risk in 10 years for relapse. And you have a binary classification. You only have low risk and high risk. So let's have a look a bit more about the genes. I don't really want to go into detail. There are a lot of publications, especially from Carsten Denkert, showing this. But we see 5 hormone receptor-related genes that are more associated with late relapse and late recurrence. And we have 3 proliferating-related genes that are associated with early relapse. So what can this test perform? It's trained and validated for early breast cancer, hormone receptor positive, HER2 negative. It's for node negative patients, but also for node positive patients up to 3 lymph nodes. It's validated in pre- and postmenopausal women. It combines tumor gene expression and the clinical pathological markers. And we have seen in several studies consistent results. And we have, Carsten Denkert and I, with our both groups in Germany, have also got prospective evidence for the conformance of this test. Gives you an accurate risk assessment for early and late distant recurrence. And it also, and I will show you this in my data, and I think this is one of the most important things, we can also see a chemo benefit estimation from the test. It shows a good performance in node negative and node positive patients, and as well in premenopausal patients and postmenopausal patients. Carsten Denkert said this already. We are performing this in our local labs. So at my clinic in Munich in Germany, we have the pathologists doing the EndoPredict test at the same lab. So those are small ways, and we don't have to send it. We don't like sending the samples anywhere. And I already said it's binary classification, so you only have high and low risk. You don't have an intermediate risk group. Of course, saying that, we know it's a continuous marker, and with some patients, you might have to discuss if it's on the edge of the threshold, what you want to do. So coming to my data, which I would like to share with you, what's the patient population? We had around 370 patients with early hormone receptor positive, HER2 negative breast cancer, some with nodal involvement, some with not, maximal 3 nodes allowed. We enrolled those patients between 2012 and 2015, and we assessed demographic, clinical, and pathological data. All samples were tested with the EndoPredict test, and up to now, we have a median follow-up of 8.2 years, which is really good in that collective. We looked at treatment compliance, local recurrence, distant metastasis, and survival. So let me share the basic patient characteristics with you, and this is a real-world data set here, what you can see, and we haven't really excluded any. You can also see that there are males in this collective. Median age is 60. We have 1/3 of the patients being premenopausal, and we also have large tumors in this collective, but not so many T3 tumors, only 3%, but T2 tumors, so above 2 centimeters, 35%. We have, of course, most of the tumors graded as 2, but 16% were grade 3 of those tumors. We have 1/5 of the patients with positive lymph nodes, and this is what we can see, and this is consistent with data that has been published before. We see that 1/3 of our patients are at high risk for relapse and gaining distant metastases. So in seeing this here in our collective, we have a 5-year distant metastasis-free survival rate for the EndoPredict low-risk group of 96.6%, and for the EndoPredict high-risk group of 85.5%. This is highly significant with a hazard ratio of 2.21. So let's look at the tumor-related distant metastasis-free survival, meaning that death by breast cancer and distant relapse. And we can here see the Kaplan-Meier curves on your left side, and you can see that the low-risk group, the green curve, is right at the bottom there, and you can see not a lot of events, and then there's sort of a plateau. And with the epically high-risk group, you see that there are a lot of events over the times, and this is seen the threshold of 5 years distant metastasis-free survival I just showed you before. Looking at disease-free survival, I just wanted to show you the green curve here. It's not so relevant. Of course, it's relevant for the patients, but the distant burden, disease burden, and in the end, the overall survival is interesting for us. But what you can see is that the epically low-risk group is really safe categorized, or the distribution is really safe, and we are above 90% here. So let's look at the important point, and a lot of clinicians don't use the tests in nodal involvement, and we see here distant metastasis-free survival on the left in the node-negative cohort, which is of course a lot larger. It's 240 cases here, and we see a 5-year distant metastasis-free survival rate from epically low-risk group of 97.2% versus 84% in the epically high-risk group. Looking at the node-positive patients, unfortunately, of course, our group here is too small to gain significance. You can see it in the p-value here. But we see a trend, and what I really want to show you with this graph here, and this is why I'm showing this here, is that 25% of the patients have a nodal involvement are low risk, categorized as low risk, and we don't have to forget that. Looking at the menopausal status of these patients, we have very good data now that it's safe in premenopausal patients. Those are prospective data, and we have a 5-year distant metastasis-free survival rate in the premenopausal patients for the epically low-risk group at 98.6% versus 86%, which is consistent with the overall cohort. Then let's look at the postmenopausal patients. Of course, there are not so many events, so it's just not statistically significant here with 0.054, but you can see the hazard ratio of 0.192, and you see the curves up there. So just a small insight, and we have really looked into this with those bulk diagrams. And of course, what you can see here, we have a different publication published a few years ago with the same cohort, looking at the correlation between grading, Ki-67, tumor size, and nodal involvement, and the test. And of course, what we see and what we really want to see is that if you have an epically high-risk test result, the grading goes up, the Ki-67 goes up, tumor size goes up, and the nodal status goes up. But what I really want to point out here is that you have in the high-risk group of EndoPredict, you also have the G1 tumors, and not so small amount, it's 10% of the patients really, because a lot of clinicians say she's G1 and she doesn't need any chemotherapy. So this is not the case. And also if you look at the nodal involvement, I have told you before that there are a lot of patients with nodal involvement, but the gene signature is very low risk, and those patients don't need chemotherapy. Looking at the Ki-67 a bit more closely, and there was a lovely session chaired by Carsten Denkert before the oral breast cancer session, and we know that Ki-67 is a continuous marker, and there have been several thresholds over the years. I mean, I remember the threshold of 15%, lower 15, higher than 15%, then it was 10%, lower, higher than 25, and at the moment now, I believe the Ki-67 working group has a threshold of beneath 5% is safe, and above 30% is safe. But just what we have done here is looking at subgroups in our cohort here, where we did the EndoPredict test. And what you can see, because this is what a lot of clinicians, at least in Germany, do, if the Ki-67 is 10% or lower, they don't give chemotherapy. And what we can see here is that there are quite a number of patients that are high risk in this so-called low-risk collective via Ki-67. So we have a distribution still in this collective, and also seeing this in the so-called high-risk Ki-67 cohort, above 25%, we still have patients that are EndoPredict low-risk here. And this is all significant, as you can see here. So this is all very nice and good, but what we really want to know is, if we identify our patients that are high risk and give them chemotherapy, do they really benefit when I give them the chemotherapy? And what we have done here now, we have just looked at the patients that are high risk, and we recommended in our tumor board chemotherapy. You remember the first slide of my data, there were about 35% of the patients, in numbers 130 patients, and only 67% of the patients received chemotherapy or gone for chemotherapy. And if you sort of think about your patient, all of you have that. They don't do what we recommend. Not all of the patients do that. So you have dropouts, and what we then have looked at is, how do the Kaplan-Meier curves run to just comparing the curves of the chemotherapy of the patient that are high risk, only the high-risk patient receiving chemotherapy, and the high-risk patients receiving no chemotherapy. And what you can see here, that it's highly significant, hazard ratio of 0.46 for patients with chemotherapy, having a 5-year disease-free survival of 89.1% versus 68.9%. And there we are again, comparing the cohort maybe with the triple-negative patients. If you see this, with a survival rate or disease-free survival rate above, beneath 70%, so these are really the patients we have to catch. So, and I want to conclude. We have an excellent 5-year outcome of EpiClin low-risk patients. We have seen that. Patients are categorized as EpiClin high risk. When they were categorized as EpiClin high risk, these patients significantly benefited from adjuvant chemotherapy. What we also have seen, that it's the distribution is regardless of menopausal status, and we can see a good classification accuracy in comparison to Ki-67. And I think it's very good that there is the combination with the tumor size and the nodal involvement. Just to let you know that it's not only us that are doing this, and we have very nice data also from Germany, from the Charité. This is Carsten Denkert's former study group, and they had a lot larger study population, actually over 800 patients. Same really enrollment time, which is interesting. And the collect is a bit different. The median age is a bit lower than with us. They have also T2 tumors. They have a little more grade 3 tumors. And they have more patients with nodal involvement. There were nearly 37%. And this is also why the distribution was nearly 50-50 to high and low risk here. And what I want to show you is that it's safe to do the test. Which we really want to know is, what is the performance and how do the patients run that we have categorized as low risk? Those are the patients who get local therapy and only endocrine therapy, and we have a very good 5-year distant recurrence at 1.6%. Exploratory subgroup analysis of the node-positive patients were only a 5-year distant recurrence rate of 2.4%. So this is the first part. So I don't know if you want to discuss this before,
maybe,
and then
maybe I would like to ask to the audience if you have any questions or comments. Please come to the microphone. I will start with a short question. So, how are you using Key 67 in your daily practice? You look at the Key 67, or you decide about genomic testing, or you would do an endopredict in all patients because you showed that there are always high risk patients there.
I really think, and a lot of colleagues in Germany laughed at us because we really do the test in nearly all of our patients, If I have a 84-year-old patient with a G1 tumor and Ki67 of 10%, I will not perform the test. But we are doing a lot broader than a lot of colleagues are doing it because we are seeing what we are seeing. And we are seeing that it's not safe in just taking one of those classical parameters. And I mean, is it realistic that you have a T2 tumor with G1 grading and Ki67 of 10%? You hardly ever have that, really. So.
Yeah. Okay, so there's the question.
Hi, this is Mark from the German Cancer Research Center in Heidelberg. I was interested in how is your take on biomarker complexity, especially also in regard to the first session. So we know that BRCA1, 2 clearly are really good predictive markers, but then we see also that HRD testing is really important for the rest. But can we go further? For example, what about epigenetic alterations? What about mutational signatures? We know there are single base substitution, indel signatures, and maybe even copy number alteration signatures that do show up in BRCA-ness phenotype cells. So now we also see gene expression profile in clinical data. So what is complexity trade-off? What is your opinion?
I think the team here, because it was mainly related to the first part of the session, so maybe you want to answer?
Yeah, and also we do have a question finally. I was trying to answer. Thank you for this question. We do have a question also for the cutoff. The cutoff is now 42. I was trying to answer that. You're right. I mean, the way we have to look at HRD is very partial. And that's why it was a terrible mistake, maybe a little bit pretentious, to say we're going to see on HRR gene panel and we will find out what are the defects. And you're right, we have to learn a lot from epigenetic, from the patient story. We should not forget the response. Every single part of the puzzle, which actually includes what you mentioned, is very important for the future to see which patients could benefit really from a target therapy. And I think PARP inhibitors in ovarian cancer is a very good example of that. If you move to other cancer, it's a pity that we do not have tools beyond BRCA mutation to see if there is subgroup of patients, maybe driven by epigenetics, whatever, that will benefit. I think this is the future to bring other, with biology, other pieces of the puzzle to understand which exactly subpopulation of patients could benefit. But you're right, we are at the beginning of this story of precision oncology. Yes.
Yeah, if I can give the opinion of the clinician, it's very complicated, to be very honest, because the number of prognostic biomarkers you can see in the literature is huge. And we have seen, like, in the last 20 years, many biomarkers which were, like, revolutionary, and at the end, they just disappear in the middle of the sea. So those who really make the difference and who are used in practice are not so many. So, but at the end, I think it's important to keep open-minded because as clinicians, we need to have a whole picture of the disease of the patient. If we take the example of ovarian carcinoma, HRD is probably not enough. We need other parameters. Of course, the surgery outcome, elements relative to the patient, the KLIM, which is the chemosensitivity, and other tests are coming. And this is what will give us a whole picture. But we have to be aware of something. They have to be reproducibly validated in several data sets, not only one, several data sets on thousands of patients, so you can start to think, yeah, there is really something happening there. And of course, prospective validation is needed. It's what we are talking about with breast cancer. Many of these signatures were prospectively validated. This is what we need.
And also, the complexity does have some limitations in translating them into clinical routine practice. Then many of these tests that have been developed, like HRD Tech, etc., that reflect these single copy number or variations and mutational signatures, they're still based on fresh frozen tissue. And it's complex to these really complex assays to translate them into something that can be done in routine clinical practice, where we have to rely on paraffin-embedded tissue, and also to grant the access. So that's one of the, to have something in the lab and then get it on the road is very difficult. And running studies to validate these assays in terms of study design, this is also quite a challenge today, having all these data.
So if we come back to your complexity question, I've been thinking about at this meeting, what would be the best biomarker scenario for a pathology institute or for a workup? So what would you really like to have? And if we say in the best world, we would have a whole genome sequencing, we would have a large transcriptomic panel, and then I would like to have defined proteomic markers that would address all the future target of ADCs that may be relevant for clinical decisions. And this is something that is manageable in a research environment, but the question is, how do we translate it to the real world? So if you do a whole exome or whole genome pipeline, if you change a little bit in the bioinformatics pipeline, you will obviously have slightly different results, which is perfectly fine if you're doing research, but it's very difficult to do this in a clinical trial scenario. And so I would expect that data from at least whole exome sequencing will enter the diagnostic setting very soon. But for the specific HRD question, we are not sure if this can replace the existing assays, because the bioinformatics PEP pipeline developed by Myriad is like rock solid. It's very well defined, and it will perform always in the same way. And whenever you do something based on whole exome sequencing, you have to deal with this problem and adjustment. But I think there will be more assays addressing the complexity, as you suggested.
Thank you very much.
So if we do not have any other questions, I think we will go on. So the second presentation by Dr. Klein will be a case study for a breast cancer patient, which is nodal positive. Go ahead.
Yeah, we can do this really quick, but I've brought a case from our clinic. It's a 56-year-old postmenopausal patient. She had a lump in her right breast. We did a core biopsy. It was a non-specific type, G2. Estrogen receptor 90%, progesterone receptor 15%, so a bit lower. So keep that in mind, and HER2 1+. She had no medical history of breast cancer or ovarian cancer. You can see here the mammography pictures. This is a contrast-enhanced mammography, so you can see the tumor in the upper outer quadrant. It's about 1.5 centimeters, no microcalcifications. And this is the sonography picture here, also the lesion in the middle of the picture, measuring about 13 millimeters, no evidence of suspicious lymph nodes in the axilla. And what we have done is we performed a breast-conserving surgery via fine needle marking sonography, and we did the sentinel lymph node. And what we got in the histologic report was then PT1C. We expected that, but we had 3 lymph nodes with macrometastases, and it stayed with G2, and those were the receptors. Oh, shoot. Yeah. And then I have a poll question for you. of course, the Ki67 is missing here. We have done this in a different session, and we did it with different Ki67 thresholds, which was very interesting, considering the answers. But to make it easy for you, the Ki67 in this case was 20%. So I would really like to know from you what you would do. Would you just go on with radiotherapy and endocrine therapy in that patient, or would you do chemotherapy, radiotherapy, and then endocrine therapy? Would you do gene expression testing, or would you even go further for further surgery and do the axillary clearance in that patient? So keep in mind 2 or 3 lymph nodes. It was a T1 tumor. Grading was 2, and we had high hormone receptors. So nobody did the axillary clearance. I hope for that, because I'm a surgeon, so this is really good. But some of you actually are doing the test in that patient, and this is what we also did, and we can discuss the case in the panel after that. So what have we done? We performed the, let me see. There you go. We performed the EndoPredict test in that special patient, and we got a low-risk result. And here you can see one of the reports here, and we see first the 12-gene molecular signature, and then we see the tumor site, the nodal status, and this is all in the algorithm and giving you the epiclin risk score. And this patient has a likelihood of distant recurrence from in 10 years for only 7%. And absolute chemo benefit for this special patient would be only 2%. And this is why we, here you can see the test results and the curves, which is really nice. When you discuss the case with the patient, you can show them where their individual risk really lies. You can tell her the threshold. But of course, these are always when they do the endocrine therapy. And what we have recommended, please keep in mind that this was years ago, so we have different recommendations for this patient collective now with the CDK4/6 inhibitors, but we told her that she will take an aromatase inhibitor for 5 years, zoledronic acid adjuvant, and we did a radiation of the mammary gland and of the lymphatic nodes and a regular follow-up. So I would really like to know what Professor Denkert would have done in that patient.
So you mean obviously I think it's very important to stratify the therapy based on the tumor characteristics. So this is a nodal positive patient, and for a long time and still in many centers, nodal positive patients are treated with a chemotherapy. I think it's very important to keep in mind that we are de-escalating in the surgical way, so we think it's not so important to count all the lymph nodes, because we realize that even within the nodal positive disease, there will be a group of patients that perform actually well with an endocrine therapy alone. So I think it's good to do this using a genomic assay. It's also good to use a genomic assay that calculates the nodal status as part of the risk score, because this will automatically make it more difficult for a nodal positive patient to reach the low risk group, and if it's in the low risk group, it's safe to do a very restricted treatment.
All right. Okay. So just for you, we have displayed here the validation data in postmenopausal women with nodal positive breast cancer disease. And you can see this was seen in a very big collective of the ABCSG 6 and 8 trial, and also in the TransATAC trial. And we can see a very good distribution via EndoPredict in those nodal positive patients here. And this is it. So we might discuss more questions, or if any questions in the audience, please come to the microphones.
So if you have any questions to the first part of the session or the second part of the session, please come to the microphone. while you are thinking about questions, I would like to make a general statement from my point of view. So I'm actually quite happy that I'm able to attend this session and to see the prospective data on the gene expression profiling, because we did the first EndoPredict tests in Germany approximately in 2011, and it took 10 years to get, with the available data, to get a reimbursement for those assays. And we now see from the center in Munich, but also from the center in Berlin, that those patients that were treated based on genomic assays in this time, that it was actually really safe to treat them. So we have now data collected in real-world populations showing that if we say this is a EndoPredict EpiClin low-risk patient, it's really safe not to do any kind of chemotherapy and to stay with the endocrine therapy. And I think it's very reassuring to have this data collected. And it's also, it really, considering that it took 10 years to implement those assays in a solid way in the diagnostic setting. I think we have to be prepared for future assays, that we have to do this as a long time project, and to be able to finally have a benefit for decisions regarding the patients. So, if we do not have any additional comments, I would like to thank the speakers and the discussants, and I would like to thank you for your participation in this session. Thank you very much.